to her. Thanks.
Sure. So, for purposes of the proceedings for the meeting, we do have a court reporter with us, so welcome. So do speak very slowly, succinctly, and loudly so she can capture our comments accurately, please, and thank you. I want to take a second to thank Pete for serving as our vice chair at the last meeting. Thank you. You did a great job.
Thank you.
Yes. I will ask the committee members to please raise your hands to speak. And let's say hi to the folks in the gallery. Good morning. Would you like to introduce yourself and who you are representing? We'll start with the front. Either?
That's me. Hi, I'm Jessica Zubak. I'm the new director of nursing practice at APRN Nurses Association.
Great. Thank you.
I'm Jennifer Dring with OAAPN. Erica Newell with OAAPN.
Thanks.
I'm Christy Petzl with Ohio Health, one of the managers of Advanced Practice. Christina Roberts, manager of Advanced Practice from Ohio Health. Kelly Blake, lead Nurses Association Nurse Archie Kiesling, we're leading nurse practice at OAAPN.
Gina Singleton, I'm an attorney with Brennan, Van and Nyman, who serve as counsel for the Ohio Association of Advanced Practice Nurses.
Jessica Davis, also with Brennan, Van and Nyman,
Jessica Klein, clinical nurse specialist representing OAAPN.
Great.
Summer Buckenmeyer, nurse practitioner with the OAAPN. And Kate Nelson with the Ohio Hospital Association.
Good morning and welcome. Reminder to silence the things that make noise, like your phones and your pagers, please. We are being live streamed and videotaped by a third party, as an FYI. So good morning to all of us who are joining us remotely. For those who wish to speak during the open comments, please be sure that you sign in. We will have public comments both during the AM session and our afternoon session. And we do have a public participation guideline that I don't actually have in front of me. Is it out? Is it handed out?
Yes, it's on the page.
Okay, public participation guideline is handed out or available for you to take a look at. Essentially, that will hold comments until during the open forum. And the committee charge is as follows. This committee shall advise the board regarding the practice and regulation of practice registered nurses and may make recommendations to the Committee on Prescriptive Governance. And for our agenda today, we have a pretty packed agenda. Next up, I want to provide some comments to kind of bring us all up to speed on where we've been over the last 2 years and longer. Those who are new to our committee received quite thick packets to review, so I hope to summarize that for you. We'll have public comments after that. We do have a guest who will be live on the phone at 11 a.m., Carolyn Bupert. And then we will have some general information and updates. We will break for lunch, and then we have an interested party meeting that starts at 1 p.m. on the 4th floor. Depending on who attends that meeting and the number of comments that may or may not be heard will determine how long that meeting lasts. If it's shorter, we'll come back up and start earlier. So for those who want to be in the room when we get started and you're not sure, just kind of be close, since we may start a little bit earlier. We have proposed revised rules regarding detoxification, so we'll definitely want to review that. We'll briefly review the interpretive guideline this afternoon and then end with some public comments.
The guideline itself we did not provide, so it itself is not going to be reviewed.
Okay, the IG itself has not been provided today in today's materials, but we'll just briefly touch on that because we're still getting feedback. Okay, makes sense? All right, great. So I thought I would start our meeting by sort of summarizing activity to date and sort of where we are and what we're doing and why we're doing it. So we'll start back in 1996, which concluded the APN pilot program. At that time, the board began issuing certificates of authority to CNPs, CNSs, CRNAs, and CNMs. This is not in your packet. This is just some notes I prepared for myself. Sorry about that. At that time, Ohio law included NP statutory definition that included CNPs may provide preventive and primary care services and evaluate and promote patient wellness within the nurse's specialty consistent with the nurse's education and certification. In 2001, the board began issuing certificates to prescribe to CNPs, CNSs, and CNMs. In 2008, the APRN model for consensus was published. It establishes a model for APRN regulation. It seeks to standardize the congruence of licensure, accreditation, certification, and education by defining the 4 rules of APRNs, which are the CNPs, CRNA, CNM, and CNS. It addresses structure and congruence of graduate education with resulting national certification in 1 or more population foci, which are the neonatal, the pediatric, adult gero, family across the lifespan, psych mental health, women's health / gender related. Adult and pediatrics are subdivided into 2 separate graduate education certifications, which are the primary care and the acute care certifications. The model defines APRN scope of practice as the culmination of formal graduate or higher degree education, which includes content from the 3 Ps, advanced physical assessment, pharmacology, and physiology, and results in national certification exam in the role and population. Specialty practice is defined within the consensus model as further specialization within the population foci and is not regulated by boards of nursing. And that word specialty was confusing to many of us. The model acknowledges that there's always a continuum of wellness and illness that requires consultation, referrals, or handoffs as appropriate and indicated by the patient's needs. As a member of the NCSBN, or the National Council of State Boards of Nursing, the Ohio Board of Nursing was involved in the review of the consensus model and found that it was consistent with existing Ohio rule and law relative to APRN. So the rule was, we did not need to do anything with those rules. The Ohio Board of Nursing receives many questions from practicing APRNs in the state, and you all received a sample of questions in your packet. In 2016, in an effort to help guide APRNs and answer their questions, the Board of Nursing published an article in the Momentum in 2016. The article was provided to assist APRNs with applying Ohio law and rules to their practice and with emphasis on population of healthcare being managed and not necessarily where the care was being managed. However, the article elicited many concerns from employers and APRNs related to scope of practice. Shortly thereafter, in 2017, House Bill 216 was passed and enacted. It established this APRN Advisory Committee, and our first meeting was held 2 years ago on June 12, 2017. As I read before, the purpose of this committee is to advise the Board of Nursing on issues related to APRN practice. One of the first orders of business that this committee was charged with by the board was to make a recommendation to either continue to follow the consensus model or to do something differently, which would most likely lead to rulemaking in the legislative process. Based on feedback from this committee and many other stakeholders and individuals, additional rulemaking is not desirable. Instead, the committee and others agreed that developing a guidance document and clarifying key definitions would be much more helpful. The committee agreed to use clear language when talking about APRN roles, population-based national certification, and specialty or specialization within your population focus. The committee also heard from nationally regarded experts, Dr. Ann O'Sullivan, Barb Safried, and today Carolyn Buppert, to learn more about their individual perspectives and opinions about APRN scope of practice issues. This committee and the Board of Nursing acknowledge that primary care certified nurse practitioners are very important to the health and wellness of our communities. The acute illnesses and conditions are well managed by primary care NPs in a variety of settings. The issue becomes, at what point does the patient with the acute condition that is high risk to become or does become critical and or life-threatening necessitate management that is outside of the scope of practice of primary care and within the scope of practice of acute care. Primary care NPs may provide consultation specific to their area of subspecialization, for example, endocrinology or dermatology, in a variety of settings, including emergency departments and ICUs. Primary care NPs may be the first responder in a truly critical situation, such as a patient's acute MI or a CVA occurring within the NP's clinic, where it's their responsibility to respond and appropriately hand off to an acute care certified provider. The term acute care has not been well defined. The competencies from NOF, or the National Organization of Nurse Practitioner Faculties, which are used to develop education standards, curricula, and certification exams for each NP population. Primary care certification does not include content or clinical practicum in the management of critical care. So for clarification and guidance only, the committee proposed to use the CMS definition of critical care. And that is that which involves high complexity decision making to assess, manipulate, and support vital system functions, to treat single to multiple organ system failure, and or to prevent further life-threatening deterioration of the patient's condition. Although this care usually occurs within an intensive care unit, it is not limited to that location. We like this definition as a guide because it brings some, and it could be used across populations. The committee agreed to use this definition for the limited purpose of the guidance document, but input from interested parties is that they have concerns relative to the effect of using this definition in the guidance document on potential billing questions. So therefore, perhaps we can find a different reference. A definition of acute care by the World Health Organization was mentioned in previous meetings, but we can't seem to find that through research. Perhaps, the discussion about scope of practice overlap does not just apply to primary care and acute care. Many populations overlap one another, such as the neonatal and population foci, pediatric and adult, primary care and behavioral health, adult primary care, and women's health. In lieu of additional rulemaking, a draft interpretive guideline for NP practice has been developed and previously disseminated for the committee's review and feedback. This was done in February and again in April, at which time the committee recommended some clarifying revisions. The resultant revised draft will not be prepared until later this summer and will be disseminated at that time in advance of the October committee meeting. The IG draft concentrates only on NPs and not other APRNs. This is because other APRN roles have different statutory scope of practice language, and the vast majority of scope of practice questions that the board receives are about nurse practitioners. The interpretive guideline pulls all existing rule and law about the scope of practice of NPs into one document, similar to what has been previously drafted for RN interpretive guidelines. It includes the CMS definition of critical care as a reference, but this is subject to change as we previously discussed. The IG includes a color-coded graphs to help visually demonstrate the typical range of patient age and severity of illness for which the CNP is prepared by national certification to manage, and it demonstrates where overlap between populations occur. Where the practice parameters regarding patient age and condition begins and ends are taken from current national certification exams. The lines indicating the degree of acuity or severity of illness are placed per the national certification description as a quick visual reference, and the age ranges reflect developmental ranges. References and links to the national certification content guides are also included. The interpretive guideline is a guideline that explains the application of current law and rule. It is not itself enforceable by the board, Rather, it is the applicable state law and rule that is enforceable. So we were not creating any new rule or any new laws, simply describing what currently exists. At the last committee meeting, feedback was provided, which was appreciated, and included comments to add additional links to National Certifying Organizations standards of practice, perhaps the NOP competencies. These should serve as the most current references and evolve as the roles and scope of practices evolve. It was suggested to clean up some wording, tweak the graphs to ensure consistency among primary and care population foci, and to use some form of a permeable appearing line so that we don't give the idea that there are hard lines, because we know that things ebb and flow. There was a suggestion to delete the graphs altogether and use a written document, which we may still take into consideration. Additionally, the Board of Nursing met with and received feedback from the Ohio Hospital Association and the Ohio Organization of Nurse Executives. We reviewed the IG with them, and the committees agreed that the IG was a good idea. They asked us to consider developing some FAQs and case examples to accompany the IG. They also provided feedback to ensure that the graphs are consistent with national certification statements. All of these comments will be incorporated into the draft and sent out to the committee and posted for further comment planned in August. That's dissemination for discussion at the October meeting. At the last meeting that was co-chaired by Pete, thank you very much, discussion was held around some topics and a few additional requests were made. To define what constitutes formal education within the population focus, mention grandfathered NPs to limit confusion, to define what constitutes clinical experience within the population focus, to consider an interpretive guideline for clinical nurse specialists, to invite OAAPN to provide further comments on the second draft IG and other topics. This was discussed with President Graves, and this will happen at the October meeting when the second draft has been disseminated. And that concludes my summary. So hopefully you found that. Okay. Any questions or comments from the committee? Nope. Okay, great. So then we go to public comments. So I have two here. Are there any other public comments? I have Jenna and Jessie.
Oh, there's one more.
Oh, there's one more there. Sorry, thanks. Just trying to get that language. Okay, great. Thank you very much. All right, Jessie, representing OAAPN. Would you like to come on down?
I guess so.
Take the hot seat.
Yeah. We don't have a timer, do we?
She's going to use hers.
Oh, you're going to. So.
I've timed it, so I know I'm not
Okay.
over 5, I promise.
Very good. So you have 5 minutes.
No problem. I think I'm at 4:30.
All right.
So I think we're okay.
Thank you.
All right, guys. Welcome, new committee members, some that are returning, some that have been here for a year or so. You're all experts in your field, and I thank you for your time and dedication to be here. It's very important. I presume you are all here to advance and protect your profession as APRNs. With the introduction of Representative Brinkman's House Bill 177, we too strive to advance our profession. But unfortunately, we have been dealing with an issue that seems to be hindering our practice because nurses are once again attacking nurses. The fall of 2016's Momentum magazine changed your APRN practice. This article has impacted Ohioans' access to care and has caused tremendous stress on APRNs, and hospital systems. Many institutions have altered hiring practices, and many health systems are now hiring more PAs and APRNs. Scare tactics have been used to motivate APRNs to return to school or find other places of employment, which is unnecessary. In a letter, the Ohio Hospital Association wrote the Attorney General, now Governor Mike DeWine, in April of 2017, stated, "There is nothing in the body of Ohio laws and regulations, federal laws and regulations, or accreditation organization standards that requires a CNP to be certified in acute care in order to provide services to patients. No other state regulates specialty practices by APRNs. In fact, Professional Licensure Board governs licensees by specialty. Physicians, chiropractors, dentists, and physician assistants are not regulated or limited by any particular specialty. It would be an unnecessary restraint of trade to restrict what we could do based on what we learned in school. Denying the importance and impact of continuing education, clinical experience, skills, and training on everyday practice is like denying the necessity of keeping up to date. OHA goes on to say in their letter to the governor that Ohio law not only permits but requires a CNP's clinical experience to be considered when determining appropriate scope of practice. The consensus model specifically states scope of practice is not setting specific. To say an FMP cannot enter into an ICU to manage their patient chronic conditions is as ridiculous as saying an acute care NP cannot run an outpatient trauma clinic with stable patients. Soon, an APRN hospitalist will need post-grad certificates in acute care, primary care, women's health, mental health in order to work and run in the hospital. Sounds ridiculous. Though they have no intention on entering these settings to specifically treat their patient's OB issue, mental health issue, or critical issue, but this committee has implied the APRN and institutions cannot be trusted. If this committee worries about safety, there are many layers of protection already in place. First, the APRN scope of practice. All APRNs are quite self-aware of their own scope, as is their APRN director within the hospital system. Second, the hospital's credentialing system. They risk significant liability if not followed correctly. Third, the hospital's ongoing practice assessments required by the Joint Commission. Fourth, the Board of Nursing's medical decision-making model. And fifth, if the APRN does go rogue, the Board of Nursing's disciplinary system, which has been well vetted. Why add a sixth layer of restriction? But for almost 3 years, we have been dealing with colleagues in nursing who have created our own practice restrictions. I can't say for sure why this is happening, but I can say the basis derives more from fear-mongering than scientific evidence. The important article by Peter Burehouse published in the American Enterprise Institute in 2018 makes the following points. State-level scope of practice restrictions do not help protect the public from subpar care. State-level scope of practice restrictions provided no evidence that patients receive better quality care. Some organizations have justified their support for state regulations to limit NP scope of practice on the grounds that they are necessary to protect the public from low-quality health care, but Peter's research found no evidence of this. In fact, his analysis found that states with restrictions utilize more resources and made care more expensive than states without scope restrictions. Therefore, restricting APRN scope practice, as this committee has discussed, would in fact harm the public, which is the complete antithesis of its mission. The U.S. News and World Report has Ohio ranked 36 in healthcare. 75% of U.S. states are healthier populations than Ohio. Every state with full practice authority for APRNs is ranked above Ohio. None of these states regulate by specialty. Many categorize APRNs by population focus, as Chairman Aaron has stated, but there's no mention of acute care and no mention of primary care. They also mention the word subpopulation. This interpretive guideline has many flaws and is unnecessary. It tries to help APRN CNP primary practice, but fails to mention clinical experience and training. Why are we trying to reinvent the wheel? Our predecessors already defined APRN practice. In fact, Ohio Administrative Code 4723-8-01, Section F, states practice of nursing as an advanced practice nurse means providing individuals and groups nursing care that requires knowledge, skill obtained from advanced formal education, training, and clinical experience.
Thank you. Thank you very much. Does the committee have any questions for Jessie? Yes.
I don't know if it's a question, but it's a comment. If we have to ask the speakers to slow down, does that impact the amount of time that they're given?
That's unfortunately.
Unfortunately.
I rewrote it last night about midnight. I'm not surprised.
I appreciate it. May I ask you a question? So when you were talking about further restrictions to scope of practice, were you referring to the interpretive guideline, or are you talking in general terms about the standard care arrangement and the current legislation to repeal?
I mean, the standard care arrangement's already in place. We are trying to get rid of that to improve access to care, but I was referring to the interpretive guideline.
Can you tell me how you see that as being more restrictive to scope of practice when it seeks to simply clarify existing rules?
It seems to the attempt to clarify is all well and good. However, there's language that's been left out of the interpretive guideline, such as clinical experience. We're trying to say that's by national certification only, including your own 1996 definition of, scope of practice for NP, but it left out the words from Ohio Administrative Code. I mean, we're totally ignoring the rule, and it's not just Ohio Administrative Code for nursing. Other Ohio Administrative Codes have also recommended education, training, and clinical experience as that licensed professional. And if we're going to draft this interpretive guideline, we cannot put the words down that we feel fits that mold. We have to actually identify a hidden Ohio Administrative Code.
Great, thank you.
So when I was reading the IG, it does mention master's or doctorally prepared degree programs. Can you, like from an OAAPN perspective, educate me about how many NPs are still in practice in Ohio that maybe have a bachelor's?
I mean, there's a
Are there
few.
some?
I mean, obviously that's, I think it was 95 or 96. I'm not entirely
So
sure
there are
when it
some.
was required. But yeah, there are some. I mean, 1995 or 96 when I think you had to have a master's. I'm not sure. I know some may know the
There's
exact
some.
date. 23 years ago. So I mean, theoretically, those will be retiring over the next few years, I would think.
Yeah.
But
And we had a recommendation to acknowledge the grandfathered.
So will the grandfather
APRNs.
though apply only to their educational preparation or to their current job function? Will the grandfather
Their
clause
scope is
apply
the
to
same.
someone, like,
Did-
I read somewhere where they said it would be kind of ridiculous to tell somebody who's been in their job for 23 years they have to go back.
Right, no, we would not,
Okay.
it would not require that. Yes, Lisa?
And just when we're talking about grandfathered CNPs, grandfathered CNPs have the same authorized scope as current CNPs. It's just what was grandfathered are the minimum requirements for them to have been now licensed as a CNP, or when they were originally authorized by their certificate of authority.
Great.
Thanks so much. Great.
sorry, I ran long.
No worries. Next up, we have Gina Singleton, representing OAPN. Morning.
Good morning. So my name is Gina Singleton, and I'm an attorney. We serve as general counsel for OAPN. Thank you very much for your time. We appreciate it. I was given a very simple task today. I know some of you are new, so we want to make sure that you all have a copy of OAPN's last letter on the topic of the interpretive guidelines, which had suggested revisions from OAPN. It also contains a copy of a letter from Ohio State with their recommendations. So I've asked to provide that so that you guys have it as you're moving forward. And I think Jesse already touched on it, but there's a real concern, as you can tell, about making sure that clinical experience plays a role in whatever interpretive guideline exists. Because, as you all know, your national certification tests you for that point in time of what you know, but your practice will evolve over time. So these are copies of the letter, and if you have any questions about it, we'll be happy to answer it. The only other thing is, Chairwoman Keels, you had mentioned meeting with OAPN or including them in discussions about reviewing the revised version of the IG, and OAPN is absolutely interested in meeting on that topic, so thank you.
Thank you.
Yeah, I
Yes.
do have a question for you.
Sure.
So the committee has agreed to support or enforce, I guess, the consensus model. That's probably the wrong
Yeah.
terminology. But the consensus model, and I know the consensus model doesn't identify clinical experience as meeting the requirements. How do you propose the Board of Nursing and this committee work with including clinical experience when the consensus model doesn't state that?
Well, I guess first of all, the consensus model is not Ohio law. And I think too, the consensus model was drafted a long time ago, and I think practice evolves over time. Second, it's my understanding there's a LACE document that's out there also that does talk about clinical experience. I think it's important to remember that. So I would say that those are some things you need to consider, and also, of course, you need to make sure we focus on Ohio law. Yes.
So it's been maybe a year or so since I read the consensus model, but it also wasn't unanimous, right? It was only passed by about
Correct.
60% vote, so not
Correct.
everyone agreed with the terminology.
And maybe it's time to look at the consensus model. That's outside the scope of this discussion,
Right,
of course, but
right.
I think something that was developed so many years ago probably needs to be updated from time to time as people see the impact on practice.
So from a legal perspective, the Ohio code would trump the consensus model?
Absolutely, yes. Ohio law and regulations are what govern Ohio.
Okay,
Thank
thank
you.
you. Okay. Next up, we have Jessica Davis, who is also representing OAAPN.
Yes, if I may, excuse me, it may be advantageous to defer until this afternoon because my comments may not be appropriate or germane depending upon other
Okay,
testimonies.
that's fine. I'll keep you right here in the stack.
Thank you.
Dr. Margaret Graham from The Ohio State University College of Nursing. Good morning.
Hi. My name is Margaret Graham. I'm the Vice Dean at the College of Nursing. I'm a family nurse practitioner and a pediatric nurse practitioner. And I'm also on the faculty in the College of Nursing. And your last meeting, we sent a letter requesting your consideration of the scope of practice for the APRN. I don't think maybe you have, do the new
Yes.
people have that?
It was included in the packet, I believe.
I have some.
Yeah, if not, we can just pass it around. I'm pretty sure it was in there. Oh, and Gina just distributed it too, but that's fine.
So I send my apologies from Dean Melnick. She was hoping that she would be able to address you today, but wasn't able to work with the agenda that you were able to work with, just due to some formal commitments that she had. Our college has paid very close attention to all of the work that you're doing because we represent so many advanced practice nurses. We have so many of our alumni practicing across the state because of the number of specialties that we have. And so we have a director from every single one of our specialties have come together, and we would like for you to think about the scope of practice for the determination of the APRN. And it does include the clinical experience. And I think that we have to think about when we started acute care nurse practitioner programs in the state. And so we have people in their late 40s, early 50s who completed family nurse practitioner programs or adult nurse practitioner programs who are working as hospitalists, have been doing that for many, many, many years. And expecting them to come back and to start brand new, I think, would be it wouldn't be beneficial to the people of Ohio. And I think Ohio Hospital Association has made that very clear. I also think we have to be very, very careful about talking about primary care and acute care. Because when we think about specialty practices, we think about primary care nurse practitioners have learned how to manage chronic disease. Chronic hypertension, hyperlipidemia, diabetes, those are all part of the cardiac specialty practice. So if we're going to say that family or adult nurse practitioners can't be there, are we saying that acute care nurse practitioners can't be there because it's out of the hospital? You know, I think that we start, and I see you, Erin, shaking your head no, but I think once you start splitting the hairs, the way I feel like that we're splitting this at the advisory board, I think we have to be so careful because I think that we'll put very well educated advanced practice nurses who are practicing and have been practicing to their scope and great peril. And I think that'll put the citizens of Ohio in great peril as far as losing many, many providers. I think we'll have people leaving the state who can. Those who can't, I think, will be very concerned about their practice. We know that some of the hospitals got rid of some of the advanced practice nurses after the Momentum article. And I just think that we think that we have to think about clinical practice as an advanced practice nurse. We're not advocating that we consider clinical practice as a registered nurse before they go back to become an advanced practice nurse. And I think we also have to think about hospitals and credentialing. Hospitals that are responsible for credentialing are certainly looking at the practice of the advanced practice nurse. And if we limit it to what the person had in their practice, then that's going to be very limiting. The best example I can give of that is a family nurse practitioner who is doing colposcopies. We don't teach colposcopies in an FNP program, but there are many formal education programs that teach advanced practice nurses colposcopies that make them very, very well educated. And so that's just one of many examples. So we request that you reconsider. I know you've discussed it because I listened to the tape, but I do request that you do reconsider thinking about using clinical practice as the advanced practice nurse and education, and that you keep this as broad as
entry-level practice.
Exactly.
So in asking us to consider the clinical training or postgraduate clinical training, to be clear, that you can stay within your population but still expand on those
Right.
specific skills. And so
Mhm.
our document needs to reflect that.
And I think an example of that would be our nationally recognized residency program in oncology at OSU. I mean, I think that there are many, many different examples of that we do not want this to be narrowed.
Well, you also mentioned that you had reviewed our discussions. I wasn't here, so I reviewed them as well, and that we had agreed on that definition as opposed to the one that's now put forth by OSU at OAAPN. I looked back at that tape, and at the 1 minute and 10 second mark, there's no agreement on the definition. So I think we're happy to include a open discussion about the definition.
Thank you.
Thank you for your comments, Dr. Graham. So I think back to certification and what happens in the certification process with the practice analysis that's done every 5 years, and that psychometrically sound process that all certification organizations go through, that's constantly repeated. So I extrapolate that now to the clinical setting. And the question I have is, without that process, how does one know that clinical practice truly reflects that this individual is competent? How do we deem that when we don't have that process in play? I think it's important. I think we all recognize that clinical practice is different all over the state. With acute care and FNPs, it can be very different. So how do we maintain that person is competent?
Well, to answer your first question, I used to chair the board of the ANCC where we did all of the psychometric, and so I did that for years. But I recognize that's entry into practice, and so we have to recognize the certification is entry into practice. And second, I think that the Board of Nursing and that educators of advanced practice nurses and professional organizations for advanced practice nurses have to work to make sure that hospitals and other agencies who are hiring advanced practice nurses recognize the importance of credentialing and recognize the importance of scope and credentialing. And I think that we can do that, and that's our responsibility. But I think that working through credentialing versus making truly, I think, splitting hairs over whether a person's practicing primary care or acute care. If they're in a specialty practice, which should that be? I mean, people are already asking that question. And in those specialty practices, I think both acute and primary care should be able to work in that cardiac office. So I think it's our responsibility to work to make sure that as people are being credentialed, that practice is there and that clinical practice is there. But I don't think we want to put it in law or rule so that we are actually restricting the practice of the advanced practice nurse so that other health professionals will be moving us out of our jobs. And I think that we will see that happen.
Being on a credentialing committee and watching that happen, what I noticed is that before an APM was represented on the committee, it was really blind by the committee to decide whether or not that person was competent. So in going back through that, I would ask you, what are those documents that you would suggest from a credentialing and privileging perspective that you would use to define whether that person was competent?
Well, I think that if we are looking at procedures, that we look, if certain procedures have to, be checked off, they have to have something that have to be done, and that I don't know that we want that to be prescribed by the Board of Nursing, but I think that we certainly want Board of Nursing and professional organizations and others, and you're exactly right, we have to have advanced practice nurses on the credentialing committees. But those are things that we need to advocate for. But I think that those have been designed well, and this is entry level. There was no way we could write a question that represented every clinical scenario that is appropriate for the FNP to work in. And so it's that entry level. The rest of it, we really count on them continuing their knowledge base once they get into a clinical setting in their clinical practice. And I think the endoscopy example was a wonderful one. You know, I did pap smears in my training, and it's within my scope as an FNP, but I certainly would need some additional clinical mentoring by someone if I were to do it now. So, yes, clinical practice and those exams are updated, but they cannot possibly represent every knowledge point that is within the scope for those certifications. The other thing I think is, yeah, sure.
So I was using that as the entry level. I think my
Right.
question was, how do you extrapolate that to the experienced RN, or the experienced APRN?
Right,
So
I think
that
as
was
you
my-
are
that was
in
my-
practice and you build on different examples and scenarios, and your practice can change to within the scope, but you can be experts in many different parts of those different areas. Like if you were in women's health for pap smears and primary care, you would need more training for that. The other thing is as far as the institutions, you know, the Joint Commission has the ongoing professional practice evaluation, or the OPPE process, which I think you were alluding to as part of credentialing. And so building measures within the Joint Commission rules to really evaluate practice and really have your finger on the pulse of what people are confident, maintaining competency. That is the OPPE task, is to be part of that process. So I think that could help too in competencies and just having ways to evaluate, good ways to evaluate scopes and practice. And so that's some of the things we kind of have done.
Dr. Graham, if I may, thank you for coming. I was very happy to see you because I wanted to ask you a question about the letter that Dean Melnick sent on behalf of the college, which was requesting that the committee consider putting some clarification around formal education and clinical experience. And so my question is this within the population focus? So for instance, I think we all acknowledge that certification exams validate entry level knowledge competency, but then in many places you need to have transition to practice programs or continuing education, CME, skills, procedure labs, so on and so forth, to maintain your competency, to gain and build upon that expertise. Is that what this letter was requesting, or was it something separate, such as a postgraduate residency or fellowship or other training program that would then prepare an APRN for management outside of the scope of practice? Because I think that's what the consensus model is really trying to limit, which is, say, an FNP or a primary care certified nurse practitioner would attend a course or a training program and then feel competent or deemed able to manage the care of critically ill patients.
I don't think that we think that acute care nurse practitioners should be doing primary care necessarily, or primary care nurse practitioners should necessarily be doing acute care if they had just entered into practice. We would like to see people practice according to the scope that they have been educated to. But we have advanced practice nurses across the state who have many varied experiences. The other thing that I don't think we require additional, transition to practice or residency. I think to require that or to suggest that should be required, would not provide the access that we need for either the APN or for the patients. So I think that what we have to do is we have to think about where the person, their experiences that they have had. Some of them will have the opportunity for residency. I mentioned the one in oncology that we have in the names. We have adult nurse practitioners and acute care nurse practitioners going into that year-long program. So that's why I say I think we will have to be careful that we don't make it so narrow that things like that can't happen. In the best of all worlds, we'll all be working in the area that we specialized in, and then we have opportunities to increase our skills in that specialty, and the COPO is one of the examples of that. But I think we have to remember several things, and that is, we haven't always had all these specialties. We have people, they started when they were family nurse practitioners 25 years ago, and they were 25, they're 50, they still have 20 more years to practice. I think that we have to be careful that we're not closing opportunities for people who've been practicing for a long time, and that we keep opportunities for new graduates so that they can increase their skills and increase their knowledge and their ability and not be fearful of their practice because we're making it so restricted.
And I think the interpretive guideline seeks to help individual APRNs as well as organizations understand scope of practice. And I think based on some of the feedback from especially OHA and UNI, that an FAQ may be a way to help clarify what the terms clinical experience and education mean, relative to staying within your scope but continuing to build upon your expertise. I also think that the whole reason we're having this conversation is because there tend to be lots of questions around NP scope of practice. And we need to be able to help our graduates and our practicing APRNs understand that. And so I don't know if you have other ideas about how we can do that aside from this interpretive guideline and making FAQs, because we've heard that we don't want to make more law. We don't want to make it more restrictive. We simply want to, and simply is in quotation marks, because this has not been simple, but how can we use what we've got and make it more clear?
I think there's several ways that can be done. One is, I think some of the questions have centered around nurses who are working in hospitals. And so I think that we can take the responsibility to make sure that we educate the administration. And some of that could be through the nurse execs. Most nurse execs aren't advanced practice nurses. They are leaders and executives. And so I think working in that organization, I think working more with hospital association. I think for us to make sure that our scope is understood is our responsibility. I don't think that we can turn to the hospital association or the American Nurses Executive, nurse execs or the OAAPN. I think that that's the responsibility for the APRN. What we do at Ohio State is we try to make sure that every single person who applies to any of our 11 specialties knows what those are. And so we do a little video, and so that they recognize that. And then, occasionally people will get into their program and say, oh, this is for me. I think I would rather do this. So we try to help them change, if at all possible, into the correct one that will match their desires and their skills and their abilities. And then we try to make sure when they graduate that they take positions that match their scope of practice. We work a lot of that in the very last semester, and I think that's our responsibility as educators. We can't stop them from taking a practice, but I think that's where working with hospitals and other executives to help them understand this is what your position description is. You are really looking for this type of APN versus this type of APN. And I think that we have to do that. I think we have to take that responsibility to do that there. But I don't think we want to do that through law or rule. I think that's not going to, that won't serve us as
Indianapolis.
Figures.
Oh,
So
you
we'll
want to come up and
If
while
we're-
we're going to have to get Carolyn on the phone while you talk, if you don't mind.
Okay.
Sorry about that.
No, no problem, I understand.
We've got lots of conversation going on.
So just
So
take minutes.
she's got
Yeah.
right at 5 minutes.
Okay, Chris Williams is here on behalf of OAPN. Good morning, Chris.
Good morning, everybody. I know most of you, not all of you, but I'm on the board of the Ohio Association of Advanced Practice Nurses, and I've been coming intermittently to board meetings, and I know there are a lot of people that on the board that certainly know my face and give me welcome looks when I show up. So, and I actually am the person who went to the board 6 or 7 years ago to ask the Board of Nursing to implement an APRN advisory committee. And we went with OSANA, ONA, and OAAPN. And it was the first time in history those three groups linked arms. We approached the board, we petitioned them, and the suggestion for an APRN advisory committee comes from the National Council of State Boards of Nursing. We didn't make this up. We didn't dream about it, think about it. That's the trade association for boards of nursing. It comes from them. So after a couple of months of deliberation, we met with the board again, and they told us that no, they were not going to have an APRN advisory committee, although they had other advisory committees. And they did not give us an answer, but they did say that if we wanted one, we would have to pass legislation. So I want to tell you that legislation is a very expensive process. It took a number of years, but we did get it in House Bill 216. Because for us, it was very important. There was only one seat on the board held by an APRN. That was 16,000 APRNs or more in the state of Ohio. That really, the issues that we face day to day are not understood in general, certainly by LPNs and sometimes not by our fellow RNs, although we are RNs also. So we felt it was very important in order to move ahead in Ohio professionally. This was the first step, so that we weren't always on the back end begging to be heard, begging to be able to speak, begging to show you what we know and share documents. So you came from that beginning. The role of the board of the committee is not to represent the Board of Nursing. The role of where you are, except for the person representing the board, Erin, is to represent the APRNs. I just want to remind you of your role, because when you become a member of a sort of a quasi-administrative committee or body, it's easy to sort of forget who you're representing, and that's who you're representing, the issues that we face in practice. And I think that some of you do it very well. Others, I'm not so sure, to be honest with you. So I just wanted to remind you of that. The other thing I want to remind you is that good outcomes have to come from good process. And good process means you collaborate with those who represent the APRNs in the state of Ohio and with other professionals. I mean, collaborating with Margaret Graham and the group at OSU is a benefit to all of us. I listen to Margaret speak, and I come back, and I leave renewed. I've learned something. That's collaborative process, not just meeting with UNI or a collaborative process. If you want to talk about consensus, if you want to talk about exchange of ideas, then foster an exchange of ideas. Bring these groups together. We have a lot to say about this. How would this look? How would that look? Does this work here? Is it your purview or the board's purview to regulate specialty practice? And I'll remind you something else. I'm an old person. I am. I was going to say old lady, but I'll just say old person. I've been practicing for over 40 years. I remember when family medicine was attacked by internal medicine and specialty practice. And I remember it well. And the reason I remember it so well is I am in family practice and I'm still working, but my husband was in family medicine. And it was quite something. And a lot of the things that were said then are said now when it comes to APRNs. And I will tell you that the executives and the directors of these health facilities look at us like we're crazy. You're what? You can't do what? The board said what? More and more we hear the move towards PAs. So and APRNs are light years above in terms of taking care of people and understanding and being compassionate. So there's my reminder. So I talked to you about the coming to consensus and working together as a group. And that's what I would define as leadership. The leadership to bring together these different ideas and to help us hear each other. And I know you have a call.
Thanks, Chris.
Thank you very much.
Thanks,
Thank
Chris.
you.
Drive safe. Okay, next up we are going to dial in Carolyn Boopert. You have her extensive CV in front of you. Carolyn is an adult primary care NP, certified back in 1985.
Carolyn?
Hi there.
Hi, can you
Hi.
hear me?
Good
Hi.
morning.
Can
It's a little
you
bit low.
Let's turn the volume up here a little bit. Big Chantel.
Hello?
How's that?
That's
Oh,
better.
that's better.
Carolyn, hello. This is Lisa Emmerich.
Hi,
and-
Lisa.
Hi, and I'm going to introduce you to our chair, Erin Keels.
Hi, good morning.
Hi, Erin.
Thank you so much for joining us. We really appreciate your time. I was just calling out your extensive CV to the committee. They have that in front of them, and was noting that you are an adult primary care certified nurse practitioner since 1985, but also
I was.
a lawyer who specializes in legal issues related to the administration of and delivery of health care. Clients include hospitals, medical practices, nursing homes, agencies, individual healthcare practitioners, and so on, and that you have an extensive listing of presentations and publications related to APRN practice issues. So your expertise is invaluable. And at the request of the committee some months ago, we were hoping that we would be able to borrow some of your time to get your perspectives and opinions on scope of practice issues. I know that Lisa has been in contact with you and has brought you up to speed on the conversations our APRN Advisory Committee has been having around scope of practice, and particularly where one scope may end-ish, such as, say, primary care, and where it becomes the domain of only acute care certification, but also recognizing that the populations overlap each other in many areas. And the other challenge we're having is, how do we sort of define clinical experience and education as it relates to your APRN practice and scope of practice. So we'd be very interested to hear your opinions.
Okay. So first, a little bit of disclaimer. I practiced as a nurse practitioner for 16 years, including while going to law school, but I let that certification go in 2015 because I don't want to keep up the clinical requirement, and so I let it go. And the other part of the disclaimer is that I know you all have lawyers, and I don't want to be accused of practicing law in Ohio without a license. So what I'm going to say is more of a policy rather than legal opinion, because I don't think you would protest, but because of the controversial nature of this topic, I don't want people who might disagree with me accusing me of practicing law in Ohio. So given that, we'll proceed, and these are policy consultation recommendations, I guess, or opinions. So I come to this because I am frequently called or emailed by nurse practitioners who have one of three issues. One would be, they'll say, should I take this job? They are commonly, say, a family nurse practitioner, newly graduated, or being recruited by a GI or other specialty practice, and the job requires not only office visit evaluations, but some time in the hospital. And they are not acute care certified. So they asked, should I take this job? And I say, well, it doesn't matter what I think you should contact your board of nursing. And they often will say, well, they didn't call me back, or I did get a response, but it was vague, and so I don't know what to do with that. And one nurse practitioner did get 4 documents emailed from the Board of Nursing, which was helpful. They included the NCSBN algorithm and the consensus model of statement and so on. But anyway, I don't give them advice because it doesn't matter what I think. I mean, I do know what I think, but I don't tell those people whether to take a job or not. A second batch is they'll ask, well, my employer has, I'm an adult nurse practitioner. My employer wants to open a Saturday walk-in clinic, and they want to be able to serve children. They want me to cover this clinic. Am I on safe ground there? And again, I mean, my opinion would be no, but I tell them to contact the Board of Nursing about that. And then the third batch would be the family nurse practitioners who are being sort of forced to see patients with major mental illness for psychiatric treatment, and the reason being there aren't any psychiatric providers in that area to take care of these people. The third being, that's really a worrisome situation, but again, you know, I don't give them advice. I tell them to contact the Board of Nursing, which of course brings it back to you all. So my worries are that if something goes wrong in any of these situations and a patient or a parent sues, that the first thing the plaintiff's attorney will focus on are the qualifications of the nurse practitioner. If it's a savvy plaintiff's attorney, I think the chances of that are high. I don't know of any cases right now where this has happened, but I would like to prevent such a situation. So you want the nurse practitioner to be able to defend by saying, I am qualified to do this by nature of X, Y, and Z, which hopefully are the standard certifications. And or in addition to that, I have this and that and this and that. So, okay, that's one concern. Another concern is that those who are doing the hiring, whether it be a private practice physician group or a hospital, they don't know how nurse practitioners are educated, and they tend to often think one size fits all. And so it's really on the nurse practitioner, him or herself, to safeguard his or her own career and practice. And the nurse practitioner, I think, needs a little something to help them not only make their decision, but to also show to their employer to offer some guidance. So I am a proponent of the NCSBN algorithm, the decision-making algorithm, which applies to not only procedures but roles. And I think it would be helpful for boards of nursing to offer that as a tool. One thing the nurse practitioners are going to want to know is if their practice is challenged, what standard is the Board of Nursing going to use in determining whether they are outside scope of practice or not? And given that the NCSBN already has this tool, it seems to me to be a reasonable thing to offer nurse practitioners and say, well, I'm not going to go through every nurse practitioner's job situation and give them an opinion on whether to take the job or not, but if you can get through this algorithm with yes answers all the way to the end after the first one, which is there any legal prohibition of this? The answer should be no, but all the other questions, the answer should be yes. you can get to the end of this algorithm with yes answers, then you probably can feel somewhat comforted. And if you can't, I wouldn't take the position or perform that role. So that's sort of my general stance on this issue. And I'll just leave it at that if you want to comment.
Thank you. I'm not sure that we've reviewed that algorithm here, and I like that suggestion. And I think we can definitely pull that up and see how and if it meshes with what we're trying to do here. Maybe that would be helpful. Yeah. Anybody else have some questions yet? Sherry?
Hi, Sherry Sievers. I'm a FNP representing practice. So, do you ever refer folks to the papers that were put out by their certifying body? I know I'm an FNP, and I work at Cincinnati Children's, and I am in a position where I'm hiring, and I often will use the white paper from PNCB that was put out about age, because we run into that. We have many patients who continue at Children's through the lifespan, right? Your cystic fibrosis, and so they remove those hard, fast ages, and it's really about, can you say that you're the expert? Are you referring patients or consulting with conditions that are outside your expertise? You know, if a CF patient who's an adult developed heart failure or something. And so we often use those white papers. Have you found those helpful? Do you refer folks to their own certifying body documents such as those?
Yeah, well, that's part of the algorithm. The algorithm, one of the questions in the algorithm is the role or practice consistent with, professional organizations' statements and so. So yeah.
Okay. Yes, Brian.
I mean, if you take a look at the algorithm, I mean, it covers things like, are you prepared to accept responsibility for, the outcomes? What do the professional organizations say? Are there resources within the organization that are going to help you with this, and so on? So I'm quite impressed with the algorithm. So not that I don't know. You are the ones who will need to implement it. If someone comes with a complaint, and I was asking sort of Lisa what the standard would be now if someone comes, say this complaint came to the Wyoming Board of Nursing, and it was the example I gave about an adult nurse practitioner being assigned by an employer to work a clinic, sole provider clinic, and the person was required to see a child, and the patient's the parent was found out about the nurse practitioner's preparation and complained to the Board of Nursing. So the Board of Nursing in Wyoming did discipline the nurse practitioner for that. I think it was a minor discipline, but then the Board of Nursing went on a educational mission to inform the employers, the hospitals, that they shouldn't be asking that kind of they shouldn't be putting the nurse practitioner in that position.
Brian?
Hello, my name is Brian Garrett. I'm a CRNA representing CRNAs, and I just have a question about your experience from 85 to 93. I have one question, and based on that answer, I'll have a couple follow-up questions. What did you do as a nurse practitioner in the Department of Anesthesiology at Johns Hopkins?
I did pre-op medical evaluations.
Okay. So the training on anesthetic pharmacology, or how it might interact with the patient, did that come from your education as a nurse practitioner, or did that come from employer training and
I didn't do anything with the anesthesia. This was just a medical evaluation of a surgical patient. So we took a history, did a physical,
just the H&Ps.
and
okay.
recommended sometimes that the person go back to their internist,
Gotcha.
and then the anesthesiologist would come through and go over that. And so I didn't do anything with medication at all.
Excellent. Okay.
I mean, other than occasionally I'd prescribe a Reglan or something.
Gotcha.
That's
Okay.
it.
Thank you very much.
Pete, then Sherry?
Hey, hi Carolyn, this is Pete DiPiazza. How are you?
Hi.
Hey, I have a quick question about your thoughts around clinical experience prior to an APRN getting their certification. Do you know of other licensed professionals where where pre-certification experience comes into play after they get their license or certification to practice in their state after?
Are you asking me if I think an ICU nurse that becomes a nurse practitioner is okay to practice as acute care nurse practitioner?
Well, no, I guess what I'm wondering is if there's anything out there, any precedent out there where someone's individual experience prior to their formal education weighs in on license by a state agency or anything like that.
No.
No?
No, I don't. Mm-mm.
Okay.
Okay, Sherry?
So I pulled up the algorithm and I have a couple of questions. So I don't see where it specifically says that this is for advanced practice. Is that correct? So it's nursing, it's general?
Right.
Okay, and then where it says, is there documented evidence of the nurse's current competence, knowledge, skills, abilities, and judgments to safely perform the activity, intervention, or role? Would that be where you would think, is that interpreted by you to be clinical practice? That's one of our issues that we have been discussing. Where does clinical fit into
I just
that?
interpreted that to mean, well, if you're certified in acute care, that would be one thing. If you, I mean, basically that, or if you have you've done some sort of residency, or, I mean, it's an open-ended question, but I thought it would include certification and other things.
I would think like successful proctoring has been met.
Right.
Yeah.
It doesn't specifically say clinical practice, but it says skills and abilities, which I would think would probably be interpreted that way.
Yeah.
I mean, I think given the questions and any specific answers, reasonable people might disagree on the whether you can give a yes answer or not. Reasonable people could disagree, but at least it's posing the question, and I think that some of the nurse practitioners might self-select to not take on some of these jobs if they had to go through this algorithm, and it gives a structure at least.
Thank you.
Any other questions? No. So as we we've had a request to put some clarity around the terms formal education and clinical experience. Those exist in our current statutes. I guess, what would your recommendation around that be?
In defining formal, what was it, in defining, I'm sorry, what was the term?
For putting clarity around the terms formal education and clinical experience as it relates to APRN scope of practice within the population focus.
Well, I would have to focus, I mean, the hard part is clinical experience. Formal education is, I interpret that to mean degree. I suppose you could, a degree program where a person, is evaluated on the basis of grade. Is formal education taking a CME class? Well, I don't know. That's, to me, tricky because you sit there, but has anybody actually tested whether you have got the information down or not? So, I mean, I'm not given a lot of thought to defining those terms, and I'm not sure that I would be the right person to opine on that.
Okay, great, thank you. Okay. Do you have any questions? No, I'm good. Anybody else have any questions around the committee? Okay. Well, it looks like we're out of, I can't believe it, but we're actually out of questions. So that almost never happens.
Okay.
All right, thank you so much for joining us. We really appreciate your time.
Oh, my pleasure.
Carolyn, thank you
Bye.
very much. Appreciate it.
Mhm.
Bye-bye.
Bye-bye.
Bye-bye. Okay, all right. Comments?
I have a comment about clinical experience, and don't throw things at me yet till I'm done. So the CRNA looking on the outside, looking in. I'm also heavily involved in education. I also do education for nurse practitioner students, and my wife's a nurse practitioner. So when I first saw the clinical experience piece in the Ohio Revised Code, because I know it very well with the ASANA, I was livid. It's like, how can they do that with, because they didn't have their training and all this, right? So I was over here first. I'm like, okay, well, they didn't have it in their training, so they can't do it, right? And then so I started listening to my wife. My wife manages nurse practitioners at a local hospital, big hospital, has a red O, and I started listening to her talk about the clinical experience part, and the issues that go into that. And then, there's no possible way, if you've been a nurse practitioner for 20, 30 years, there's all these new specialties popping up, there's new procedures, there's new drugs, and all those things. And so I started going away from, they don't have the education and training, so how can they do that, to, I started moving towards it, right? And then I started thinking about anesthesia practice, and started thinking about all the new procedures. And then I am actually asked to train attending and primary care physicians on procedures. And I know this is procedures that, there's population foci, on procedures such as intubating, and they'll tell me, I didn't get any of this in my residency and didn't do this stuff, and so I have to sign them off. Now our medical director comes in and just makes a slash and takes his name, and so they're getting that as their practice evolves. And I heard about the family medicine and interventional specialist. So I can think from on the outside looking in, being not a nurse practitioner, but being around, I've changed my opinion from, hey, they didn't get in their training, so they shouldn't be able to do it, to healthcare has evolved and healthcare is different, and I see your other specialties, I see your other medical professionals, physicians do it. We have to do it in our own. I've watched our standards for anesthesia education change over the years. And also, for example, if you're an OB, get OB training as a CRNA, but then you don't do it for 20 years and you go back, well, your hospital's just not going to walk right in the OB unit. They're going to make sure that you have this clinical experience training, whatever that looks like, which they're trying to do. So I liked what she said with this decision-making model, because at least it's some kind of guidance for people, because I was reading through it a minute ago, and I said, wow, that's kind of the decision-making that we have to make. One is ourselves as practitioners, but also the hospital has to make its credentialing. So I don't know, that's my outside looking in. I'm the new person to the group, but I just want to give my thoughts and experience.
I actually don't think you're far away from where we've actually been. I think, I mean, we've had turnover, but at our last committee meetings, I think we all agreed that your formal master's degree program is your formal education for entry into practice, but that your job changes over time. The scope evolves over time. The example that one of our former members gave was asthma care, which was once considered a very acute illness. That should be managed by acute certified people, perhaps. But now it's a well-established chronic condition. It's well in the wheelhouse of primary care certified providers. So I think that's what I'm thinking about this education and clinical expertise, is it builds upon your expertise as you transition from novice to expert, or from one maybe job to another job, but still within your population focus. Like, so for my example, I wasn't here last time, but there were some questions or comments around the NNP role. And we are certified to take care of patients up to the age of 2. If you query most NMPs, they will say, I'm not trained to do that. It's in everything. It's in the NOP competencies, it's in the NAN position statement, it's in our NCC certification standards guidebook. But many of us did not train in well baby care beyond the newborn period. Many of us did not do practicum in that. But it's within my certification, it's within my scope. If I wanted to leave what I'm doing right now and go take a job in a neonatal follow-up clinic or even a well baby care area to see patients up to 2, I would need more education and training within my population focus so that I could develop competency and expertise to do that job. I think that's what we're saying.
It's like asthma attack under anesthesia is called a bronchospasm or acute asthmatic attack. That's the most acute, but a nurse practitioner wouldn't walk in and take care of it under in my population, which is anesthesia, and I wouldn't try to go to an outpatient facility and manage that same asthma attack under.
And so I think we are splitting hairs, and I think an FAQ might be helpful to sort of maybe put some guidance around the guidance document. Sure.
I think it depends on what we put in there.
Yeah.
I think, again, going back to the references that our certifying bodies have put in place.
Yes.
I know a lot of them have great white papers. And I think that's a very good observation that you made, Brian, because the difference between anesthesiology and primary care, we had 600 hours. I mean, 600 goes like that, right?
Yeah.
So, and it was in a wide variety of settings. You might have only had 60, 120, 240 in different areas, where in anesthesia you probably had way more than that, and it was all in anesthesia and or all in neonatology, right? So it's very different when you're trying to capture, and to not include some sort of clinical practice beyond that entry level would really be missed by this group, because you just can't do it. You know, even acute care, depending on the variation of what they got, some of what I'm hearing, the acute care folks, for their primary care experience, were going to camp for the week and observing kids at camp. So it looks very different, and you have to continue that once they get in a job
And I think you hit on a key element is within the interpretive guideline, we've got recommendation to reference back to those statements, because those will evolve over time as the scopes evolve, as the roles evolve, as the population needs evolve.
I just, a little question for clarity. I know that we're not really talking about the interpretive guidelines, but we keep talking about
the interpretive guidelines.
So it's not on the agenda for us today, but I just want to make a quick comment about something that you said about the national certifying white papers. Didn't you say at the last meeting that those interpretive guidelines were kind of based on those white papers from the national certification statements?
Correct, and let me back up. We didn't redistribute the draft or a redraft of it. That's what we meant by not being on the
We can still
agendas.
talk about it.
Yeah, but we can still, it's on the agenda to talk about it. So the graphs or charts on the draft IGs those parameters were taken directly from the individual certifying organizations.
Right. So that's what I thought. Okay.
Yeah, which are great resources.
Yeah, those are.
I send them to folks all the time. They ask me what, and I say, read this. And if you can answer that you fit in this.
Those are your living documents.
Sometimes the answer is no, and sometimes it's yes.
Yeah, Michelle.
So when I was thinking back on what Carolyn mentioned with these decision-making tools, it just kind of struck me that those are very generalized to either nursing or to all APRNs. This is only for CNPs.
Right.
So, as the midwife representative, there's nothing in here for me.
Yeah.
So, would it perhaps be better to have either something that's more global and addresses us, referencing white papers and referencing our national guidelines, or to just use our current decision-making tool that's on the Board of Nursing website, which does address all of these things.
Yeah. So that was a concern and a recommendation, and going back to all of the past discussions over the last 2 years has been really around NPs, which is why we decided to make an IG for NP only at this moment, but because the board receives the most questions on NP practice, and that's where there seems to be I get the most questions. But you raise a good point, and if the NCSBN algorithm could be used, I mean, there's probably no reason we can't have a link on the board website for all APRNs to take a look at that.
Well, I'd have to look at it first to see if it's really addressing nursing. It may not fit our needs, but to have something similar, rather than make it specific and restrictive for one group of those 4 nursing specialties as defined in our ORC, why not make a global one? If we're talking about the hospital practice.
So, I'm
Right.
sorry, I see your hand up, Jody.
That's okay.
So one of the reasons we wouldn't be able to make a global interpretive guideline is because each of the 4 roles has their own statutory language. So it would be challenging, other than to use like the NCSBN, a very generic sort of model, which I'm sure that, I mean, it's publicly published and available for all to use. We could probably draw attention to it. But yeah, Jody, I'm sorry you can't.
That's okay. So I think there is a very global one already currently on the Ohio Board of Nursing, and I agree that the NCSBN one is very global as well. But I think the whole purpose of this was, and you can correct me if I'm wrong, but this is my interpretation of it, was to give better, in an attempt to clarify some things about what we've been talking about for the last 2 years, which is focused around primary care versus acute care and population-focused certification. So I think that we can't lose sight of that we all have different population certifications. That's the way that our nurse practitioner model has been formed across the country, and it is what it is. And so we have to practice within that. And I think the goal of this, however, I think it sort of fell short a little bit, in my own personal opinion of that, was to give clarity to all nurse practitioners practicing in the state as to what really their population is. Because unfortunately, as an educator, which is who I represent here, I can tell you that a lot of graduating NPs don't understand what their scope of practice is. There are a lot of questions that come after graduation that I keep in contact with multiple students who have graduated and are taking jobs, and all population focused, mostly family and acute care, most of the questions that I get from students, and they don't know. And I think it's also important to, there's been a lot of conversation today, both from public comments and around the table, about this being limiting people. There's nothing limiting in an interpretive guideline unless you place the limits there yourself, or an employer places the limit there themselves, because this is all stuff that we already know when we graduate as a nurse practitioner. And I don't think anyone is saying that there isn't something valuable in clinical expertise or clinical practice that you gain. But I think it's important to remember that that clinical expertise does not, therefore, eliminate the fact or allow you to practice outside of your population focus. So a family nurse practitioner, I think this is what you were alluding to with Carolyn, but I'm not sure she really felt like she could give an answer without overstepping herself a little bit. That's kind of the feeling I got. So like, you're a family nurse practitioner and you're working in a hospital and you're taking care of cardiac patients, which is all fine. But that moment when that patient becomes unstable or has an acute coronary syndrome, are you, because you're there, should you be taking care of the acute coronary syndrome? And maybe you have in the past, and maybe it's something that you have clinical experience in either before your graduate education or after. Does that mean that you are therefore capable of practicing? That's within your scope. And I think that we can't lose sight of those little things, and it is gray, and I think it's going to be really hard to come up with something that's very specific. But I do think that we have to be careful as a group, and which I think Chris alluded to. I don't know if she's here anymore. She's going to Indy. You know,
Here she is.
that I know as for myself that most of us at the table, we are here to represent everyone and not one individual group. However, we're all going to have different opinions about it. But I just don't want to lose focus of interpretive guidelines versus law,
I don't think anyone at this table wants to enact more laws over NP practice. I don't think that's the goal of anyone, but I don't want to lose scope of interpretive guidelines just to give clarity to what it means to actually practice within your scope.
So I can address when I mentioned the limitations or the restrictions, just as a new person kind of coming in, because I wasn't here when we initially had the interpretive guidelines. One was the grandfathering, which we've talked about. Two was any of the continuing education. 3 was the bachelor's. And then I went back to the Ohio Revised Code, and I keep going back to the specific passage of 4723-8-01 paragraph F, and it says the practice of nursing as an APRN, in your definition, means providing to individuals and groups nursing care that requires knowledge and skills obtained from advanced formal education, training, and clinical experience. And Aaron's the only one I've heard say the word training. So when we struggle with those 3 areas, it says, this care is described in 4723.43. My concern when I say limitations is, one, the definition of critical care wasn't accepted by this committee, at least at the 1 hour and 10-minute mark that I looked at. And I watched the entire tape, so that was a limitation. 2 was, so we needed to work on the definition. 2 was the word training. So we talked about our certification being our knowledge, and then we talked about our clinical experience, but there's training in there. That could be our residencies, our conferences, our whatever. That's training, and that's in the law already.
Right.
So those were the limit. When I said restriction, I think if we don't mention those, we are amiss.
But I don't think anyone is debating that, what is stated in the law. What I'm saying is that all of those things come into play and are important in practice as an APRN, 100% for sure.
Right, but
And
they're just not in that
certification
document.
only allows for entry-level practice. And as we all know, I've been practicing for 15 years in the same specialty, that you don't get good at what you're doing until you've been doing it for a while, right? The first year or 2, you're still learning how to do your job, but we can't lose. And I think that the whole purpose, this conversation that I've only been part of for a year as an insider, but as an outsider, I've been part of for 2016, 2015 when it started, working at an institution in the city where it was sort of the epicenter of the whole debate. So I just don't want to lose sight of that. I don't think anyone's training and clinical expertise matter, but they only matter when you're working within your scope. And I think that that's what this whole purpose and conversation should be focused on, not on acute versus primary care. Let's just focus on standard of practice. Are you getting clinical expertise? Are you getting training within your population focus?
I think we do all agree on that, but my concerns were those aren't written down.
Sherry had 2 quick things.
Yeah.
I think we're saying the same thing.
Right.
I think we really are. When I think about the 3 examples that she gave, so the FNP, GI or specialty, time in the hospital, I think what I hear you saying is you really have to understand what it is that they're being asked to do. Because I would push back to her to say, if their time in the hospital is evaluating patients for things that they might do in the outpatient setting, like rounding to help the nursing team or the general, our people round and help the hospital medicine folks understand what a clean out looks like. It certainly, she's not managing acute abdominal, but she's doing what she does in the outpatient. It happens to be in the inpatient setting, which is totally appropriate for what she's doing. So the other person forced to see major mental illness, I think it's tough because I was more confused by this. I'll just say that as the newbie.
I kinda was too.
Holy cow. And I think the thing I struggled with is the continuum of health with the patient, because where does major medical, is it right here below where I can take care,
Is it
or
orange
is
or
it
red?
up here? What is the definition? So I think having things that, what you're saying, make us too focused and too narrow were not helpful. I think this would stem a lot more questions, in my opinion. So I think it's just being broad enough where we can help people ask themselves those questions. I tell my folks, if you're on the stand, could you say, absolutely, this is how I am prepared to take care of this patient, considering what is in the rule and what I'm legally protected
Yeah,
to
I
do.
think you're spot on.
Exactly,
And all of those comments were received about the
Right.
graphs, and we're
Yeah.
gonna see. We'll tweak it, and if it still seems like it makes more questions than it
It would be nice to
answers,
vet it through some people.
Yes.
Like if I showed it to a student
it's
and said.
publicly
It's
posted,
been out there.
so
Yeah.
I've
It's been
shown
out
it to
there.
my students.
that away. Yeah.
I think that the overlap
like-
is good. It's the continuum
Yeah.
of care, or the critical illness continuum is very
So
hard.
I think we're still wrestling with what are those
Good.
scope of practice parameters. So to say that
Yeah.
education, training, clinical expertise within that population. Pam, you had your hand up.
I think I hear absolutely both your sides, and I think from an employer standpoint, the difficult piece in this is making sure that new or relatively new person coming out understands their scope when they're in that setting, and I don't like using
Right.
that. To know that they're in the appropriate scope, and that's what's really hard. Then what do you do as an employer? Do you hire an FNP? Do you hire an acute care? How do you differentiate that? Because the bottom line is you have a patient in front of you that needs help, and I
Right.
don't think anybody's going to walk away from that, and that's the difficult piece. My other comment, and I haven't had time to kind of digest the NCSBN algorithm. The one thing, and I want to hear from the committee if you feel the same way. The one thing that's a little concerning to me is in a couple of these questions they have practice setting, and I feel like that is counter to the consensus model. And so as we evaluate that, I would just ask that we consider that.
That's a good point, because we have been trying very hard to say it's about the patient's needs and severity of illness, not the setting. That has caused many more questions and
Which, going back to
confusion.
referring people back to their certifying
Yeah.
bodies, I think would
Yeah.
I just want to, just completely side note, I've heard the term thrown around a lot, and I just want to be very clear that we're really not talking about credentialing, we're really talking about privileging.
Right.
Okay? Credentialing is
Right.
not the same thing as privileging. So we're really not talking about a credentialing committee credentialing that person is who they say they are. They really do hold the certification. They really do have a license. They check the national database that there's nothing pending against them. We're talking about privileging, where the group then allows this individual to perform certain tasks and care for certain types of patients in the hospital.
Yes, you're right.
Medical staff.
Right.
So that's
Completely two different things.
Thank you. That's a really good
Right, and that's
point.
one of the thing I liked about the OSU, I forget who the author was of this, but on the OSU suggestions, it said clinical scope of practice may be further delineated by the employee institution organization. I took that to mean their DOPs,
Yeah.
right? That's their delineation of their privileges. So it could be more restrictive, it can't expand on your scope, but it could be that individual person being privileged to do that particular function.
And so maybe it makes sense to, I don't work on a credentialing committee, I'm not part of privileging, I'm an educator. So it's not something that I do on a regular basis, but, it seems that there needs to be more, as Dr. Graham referred to, more education on the privileging part of the credentialing committees as to, and again, this, if it comes out to be something, could be sort of a guide, the interpretive guidelines from the OBN.
Yeah, and to that point, you're spot on. You're spot on, because we get lots of questions from employers as well, and through our meetings with OHA and UNI, we've been able to have some really good conversation. I mean, it's been very robust, and there's been a lot of understanding and collaboration there, and I think there's opportunity to continue to work with employers on their levels of understanding that then would transmit to the privileging process to ensure, all organizations are, sort of up to speed. I also think that there's an opportunity to continue to work with the educator side as well, so that we do have graduates who understand their scope. I appreciate that OSU is doing a great job with their students, but that might not apply to everyone. So think about what are ways that can happen as well. So, Pam.
The other piece, there are organizations that do not medical staff privilege outpatient advanced practice.
Yeah. sure how to reach that, but so that would be a good question back to the OHA. Yeah. Yeah, Michelle.
I have a question, Erin. So when you said that there were some concerns expressed over the graphs, et cetera, that we could tweak it, et cetera, is there a work group or someone that's working on these? My concern is, having been here for a bit, getting things done in 3 meetings or 4 meetings or whatever a year. So she's pointing
Lisa
at
and
you,
her
Lisa.
staff are working
But
really
can
hard.
someone else, rather than them put it out and us debate it and redo it and put it out, let's debate it and then redo it, could it be more collegial when we're developing those? Like, can the OAAPN, can people in clinical practice help with constructing that maybe, so we don't have to keep just giving a suggestion and then more work for you to go back and do it again and we talk about it again?
Well, I believe since it's a board product, it needs to be emanated by the board.
But it could be collaborative with input, right? I mean,
It's getting
so-
lots of input, yeah. And we will be meeting with OAPN, and, we met with OHA and UNI, and we're getting input from the individuals. It's posted online. So is there something further you want to address with that?
No, I mean, that's why we did not redistribute it, because we're getting so much input. And so we really wanted to give, us, staff, simply because we had an extra board meeting in between, the short time period between last meeting and this meeting, and we got additional input. We chose not keep sending out little tweaks, just to send out one good document that seems to be, that we would need to
Is that what we'll
respond to.
discuss this afternoon then? Is that what we're?
Well, we're kind of discussing it all through the meeting. We're not going to go over it line by line again. But you've been given it, so you can take a look and provide feedback to Lisa and her staff.
And the goal is, once this, is to have a significant draft, disseminated, our goal is in August, and to give plenty of time and input from people before this committee convenes again in October, so.
Brian.
And at that time, I'm sorry, at that time, once it's disseminated, if there's, anyone can proffer any revision back to us, that they, mark it up, edit whatever is believed to be appropriate by any individual, and then we'll listen.
But we have been working on this for 2 years. In the meantime, the board continues to receive oodles of questions every month from APRNs who are asking scope of practice questions. So I would hope that we can finally come to a decision and get something posted that can be very helpful back to APRNs and other organizations.
Stop minutes has been discussed before, but why don't we just call it guidelines with FAQs? Why does the word interpretive have to be in there?
I don't know.
Because when I listen to everybody talk, they have a word with the words interpretive guidelines. And I think the word interpretive is the problem. Why couldn't it just be guidelines with FAQs? Still do the same thing, but as soon as you put the word interpretive, it implies that some magic power came down and I interpret, and this is it implies maybe we're going authority towards law, right? When we're just trying to give them guidelines, right? Can we just call it guidelines with FAQs?
Well, not from the Board of Nursing, because the Board of Nursing is charged with enforcing the Ohio Nurse Practice Act.
So we have to use the word interpretive
and
in there.
Interpretive is, well,
Gotcha.
the law, any guideline, and the guideline, the board has adopted other interpretive guidelines before for RN practice. We just not needed in the past to do one for APRN practice. And so the whole idea is that it's assisting with the application of enforceable law and rules to very specific practices. In this particular case, it was determined by this committee that an interpretive guideline for individual CNP scope of practice was needed. And so that's why, and it's called interpretive guidelines because that's what's been adopted by the board or will be adopted by the board.
So we chose, to remind everybody, we chose that route instead of going back through the legislative process and opening up the Nurse Practice Act and changing the law to further define clinical expertise, training, and education. People felt we were
I'm just trying to find a way to soften the optics of the word interpretive guidelines. So it doesn't create,
because people felt, and this committee felt, to take it that way would be more restrictive and more unwieldy than simply trying to clarify what's actually in rule and law. I'm sorry.
Correct. And just to clarify too, for purposes of this committee, it really wouldn't necessarily take a law change. It was really just an administrative rule change is what could be done. And the board could certainly go that route if it chose to do, or with recommendation from this committee as well. Because a administrative rule could be changed through the rulemaking process. But that's not a direction that this committee, I've heard from this committee that they want to go at this point.
At this point, yeah. Sherry?
Is it also a possibility, I heard you say, I listened to the recording the last meeting, tried to get caught up, that you asked, do we want to include this? I believe that was your question.
Get rid of the chart.
Right. Is that still something that this group could consider? And could we, are we now in the position where we have to implement an interpretive guideline even if we decided to have something that was a reference to either this or some other documents? Do we have to go that route? That was my question. And then just because I think that it's a slippery slope once you, even though it's an interpretive guideline, I think this is what you're getting at, it could be interpreted, even though it's not in rule, in legislation, or in litigation, it's going to be looked at. So I think we have to be very careful that we don't hurt the very same people that we're trying to help, right?
I mean, Lisa had her hand up, and then Pete.
No, when this committee began discussing some type of guidance document, this really started out as just a Word document, like a white paper almost.
Right.
And then it was thought it was getting a little too lengthy, so that it needed just to be a quick reference. So that's why the chart's included with just a very 2-page IG with the. So it could go back to just a document in and of itself.
Simple. Okay.
I think the bottom line is we have to come up with something to help people answer those questions.
Right.
And to keep them within their scope. Nobody wants to harm a patient, and nobody has.
Right.
But also nobody wants to step outside of their scope, and have corrective action for that. So, and that's where a lot of those questions are coming. Can I do this? Can I do that? What about this? What about that? And there needs to be something. I think through the hundreds of questions that are received, there's a need, and if there's a better way other than rulemaking or the interpretive guideline, I think this committee's open to it, but I don't know that we've found some other method that could be helpful at this point.
Okay.
So Pete had his hands up.
I just wanted to make a comment because Jody and I this is our second year, and I know this has been going on for some time. And what I would love to see this committee do is start wrapping this up because we have rules pending to advance practice in the state of Ohio. I think it would be really hard for people to support those rules or that pending legislation when we as a group can't even decide what the heck we're doing. And I think that's really unfortunate because it's coming down to more of egos and being what can we do and what can we do. And we really are here to protect the public.
Yeah.
Right.
And advance our profession.
Right.
And it's not. So I hope as new committee members we can move this forward.
Yes.
And then move on to more pressing issues for advanced practice.
So just to Brian's comment about the title, I agree. When I was looking through the information that was given to us, I noticed the consensus model uses the term decision-making tool when it was referencing scope. Can we not either stick with that or label this specifically CNP? Because a nurse midwife or someone in another specialty is going to look at that. It doesn't say just for CNPs. So if we're going to give an interpretive guideline for a specific group, can we change the title?
I thought it did.
At the very top, it'll have to say like something specific about that. Or my recommendation would be use the decision-making tool. Because if you referenced an employer back, if you called and said, look, I'm going to hire this person, can they do this? Look at our decision-making tool. Look at yeses.
I think the interpretive
The
guideline
Ohio.
is
We
a
have
little
the
formal.
Ohio.
FAQ is a little informal, and we just need something softened in the middle. Just call it something and go with it and put forward our
Right.
So the decision-making tool that currently exists is around task.
Right.
And what we're trying to do is around scope and managing patients.
So do we tweak
So it's a
the
little bit,
decision?
I don't know that, I don't know the answer to that question. But I believe, and I don't have the guideline in front of me, that it is labeled for CMPs only. And it tries to clarify, this is not new rules, just simply trying to clarify existing rule and law. And maybe it's not at the top, maybe we can just go ahead and put it up at the top.
Probably just make it more prominent.
Put it in really big capital letters or something like that in
Just
red.
so it's clear,
I don't think it was on the chart, but it was
Right.
on the other.
Yeah.
That was
Yeah,
attached.
it's not
I don't have
it's
it
the
with me, but-
title, it's like the second line, it just says interpretive guidelines, so it depends on how it's
Sure.
phrased, or
And
just to be
probably
clear
why,
for everyone.
the intent of it,
Yeah.
sure, absolutely. Yes,
Maybe
Sherry?
we could come up with something like this, but
Mhm.
it just used very generic. Is it within the Ohio law and rule? And then we reference those numbers.
I wonder if
Is
that
it
would
within
be
your,
like the
your scope of
FAQ.
practice? Right,
Mhm.
and then it's kind of like the tool, and then have the resources for the certifying bodies. So like a series of questions, and if they work through every single one of those,
But that's
as
the
best
problem.
we could.
That's what this is trying to solve, is that second question. Is it within your scope of practice?
Well, the referring
Because
to the
that's-
certifying document,
Right,
the
but
white papers.
that's the problem, is that's what this committee has been arguing about for 2 years, is that the board continues to receive numerous questions about what is scope of practice and what is within their scope of practice. So that's the whole purpose of this, was not to a decision-making tool on how to be an APRN or a CNP. It was, what is within where does your scope start and end within a very gray area.
Right, but like I said, sending them for what I send my folks for the PNCB is the white paper on, it has all the areas, it talks about what and if they read through that, I send them that and they go, oh yeah, I see where you mean, that really would not be something I would wanna do, and then we
Yeah.
decide, no,
And we
that's
definitely
not
plan
where
to
we're going.
include those links.
So
Yeah,
that
and
could be a question, and they read through that, and then
And I
they-
think the purpose of this, however, is exactly, because that's what they used to create this, was to make it simpler, so they wouldn't have to read through a big document, was the purpose of this.
That was in your
I'm not
packet.
saying, yeah, I'm not
Right.
saying that is a perfect thing, because I had a lot of
Yeah.
issues with it at our last meeting.
yeah.
There's probably a
Um,
way to clean it up. a little bit.
So
figure
I'm
it
just
out
saying
today.
that I think it's needed, not because I like it and I think it's the best thing ever, but because I think there are still a lot of questions outside of this room as to what falls within the scope. And simply referring them back to their certifying bodies, white papers, is not sufficient from an NP. It should be, but it's not. And it's just, there's continuing to be question after question after question. So I think it's good to have something very simple, whatever you wanna call that, FAQs,
Yeah.
interpretive
I
guidelines.
just don't know that we'll capture every clinical setting.
I don't
and
think
then
we
I
can.
think that's
We're
where
not
the-
trying to, though.
I think we have
That's why it's
to
not setting
all
specific.
acknowledge
Yeah.
that
Or
there,
It is not
Not
setting
setting
specific.
specific.
Yeah.
Population.
and that there will continue to be gray. We
Yeah,
can't
right.
possibly anticipate every clinical or patient scenario, but
Right.
help just provide some guidance to make the best decision that the person or the organization can. And whatever those questions and answers are, is what we need to find, that is needle in the haystack. Pete, did you have your question hand up? Oh, Lisa had your hand up?
No.
Anybody else have their hand up? Okay, well, thank you. This is a great discussion. For those of you who are just joining us, thanks for just jumping right in, and it's apparent that you guys have been staying current and updated on where we are and what we're trying to accomplish, so thank you for that. Next up, we have general information and updates. First, after that, A is legislative report to the board, which is Mr. Dilling, who is over there, deep in thought. Wow.
Very interesting discussion. So you have my May legislative report.
Mhm.
For you all, I think you're all interested in House Bill 177 and
Mhm.
House Bill 224. We have all kinds of people of agreement, but how that looks in the sub-bill, you know, how much agreement that is, I think there's still potentially ways to go. But people are smiling at one another, and that's a good sign.
That's a good thing.
I think that they've gotten away from a formalized protocol within an institution, and fall back on the privileging and what's being done normally in every hospital today, right? Really, and there's no reason to change the way that happens. So I think that there are some time frames that are being attempted to be put around that peri-anesthesia practice, and then the clinical support functions, which may or may not be further defined. I think that's we'll see what happens, in that regard. I think that there had been some movement in the bill that had been introduced, quite frankly. So we shall see. That looks encouraging. House Bill 177. After listening to the opponent testimony, there were a lot of questions that were raised. I thought both sides did a good job in presenting their testimony, and I think that there'll be interesting party meetings and see what can be worked out. I don't know where you go in terms of the middle ground in that, but I'm not there on the inside. As with 216, mostly the associations talking about you'll hear things, here, but I don't know what that tells you as to, is this all in, get rid of the written standard care arrangement, or is there some possibility? Certainly the physicians, both nationally and here in Ohio, echo the refrain of team-based care, and somebody's got to be in charge of the team, right? There's always a captain. And who do you think wants to be the captain? Everybody wants to be the captain, right? Who's going to vote in the captain? The institution? Well, it's not all institutional practice. It's hard to define, globally some of these practice questions. That comes into play here when you're talking about some scope issues as well. That's what makes it tough, and that's why there's a political process. And where it is open, again, I think you see at least a lot of arguments being put out on the table, people focusing a little bit more as to what the next steps are. As for the other things in that memo, if you have some questions of how that applies to you all or to us, I'd be happy to answer them. I just don't know, how interested they are in military licensing, temporary licensure, things like that.
Sorry. I actually do have a question about the military licenses. Retired military officer.
Great, I don't mean to, that's not a comment on it.
No. So I did have a question though, I was reading through it. It specifically addressed people who'd be moving to Ohio, and in order to expedite those licensures so that they can provide care for that military population. It did say the words active duty. Has there been any consideration to the people moving to Ohio to practice who would be retiring here? They will no longer be on active duty as the day they arrive, but they still have to go through a lot of the same processes.
That's a good question.
So
The
veterans.
bill, yeah, right. The bill, for both the military and spouses were, focused on the active military, because I think that's the most concern for the branches right now. Okay, they want to keep people moving forward. You hear a little bit about people don't want to overbuy or whatever, and they feel like if they ask for too much, it's going to be, I don't know, how much can you ask for too much with the military? I don't know. They pretty much for the military stuff.
I just was
At
curious.
least it's heard several times.
Right.
I
was just curious if there was discussion about that, because it was striking to me that it was only the active duty, when the veterans group, the retired folks would have for the identical reasons would appreciate that.
There have been side questions, there was direct questions about reservists and people different statuses, and I believe one of the statuses was added on to it. But again, there's a lot of hemming and hawing when they're answering those questions. It's still got a ways to go, and I think that is on people's minds. I think the bottom line from the board's perspective is the system that's been set up already through, come up with expedited, licensure, it's working. All these people who check off the temporary license and military spouses, they're getting licensed in a day. Now, the kind of hidden secret here is that the way that it's drafted up is dependent upon getting in your background check. And that means supplying your background check. Actually, I have tried to tell people you are fighting against yourself here. You are going to put an additional burden on certain people by doing it this way. Because the way we set up our rules, we do not require that background check up front. We require that you start that process, and it's going to finish up within the 6 months when you get your full license. But we are giving great faith and credit to the other state in terms of them keeping an eye on that part of the situation. And that, under the statute and under our current rules, would evaporate immediately if we found out that we did have, something back in the temporary nature of that license. So that's the public's protection there. And greater minds than mine say this is what they want. This is what the general wants in Washington, D.C. Okay. I'm not all that concerned about it for two reasons. One, we're going to have to report back statistics, and someday, if in fact it does work out that way for some people, and they start calling, then somebody's going to say, well, maybe he was right, But also, I think that we could probably maneuver our rules in such a way, even though somebody could make an argument about it. No one's going to make an argument about it if we go into the rule process and say, hey, this is the way it works, and it works with you, just let us do this. The third option, too, is that the way e-license, which we're really a beneficiary of in allowing it to be done so quickly, I don't see that the statute gets rid of the current temporary window. It creates almost a separate 6-year temporary license. Sounds like jumbo shrimp, a little bit of an oxymoron. 6-year temporary license. That's really what's being created here in the military. So that's for, in large part, let's keep right past the Air Force Base, and let's keep the military formats here in Ohio too, and keep us competitive. So we don't want to rain on that parade.
Thanks, Tom. Certainly, we've really appreciated hearing from Osana and OAAPN on the status of your bills. Do you happen to know when the next rounds of testimony are?
Yeah, actually, there's a all-in, anybody who wants to testify tomorrow for the House Bill 177, the APRN bill, and then I think they have an interesting party afterwards. So this is maybe some more details. And then the CRNA's bill will have that sub-bill introduced, which will, then people can more focus their thoughts and what happens, following that. Again, perhaps somebody will come up and tell you a little bit more specific on that, or we'll just wait and see, what happens. This is mid to late June. Budget bill getting closer and closer. They tend to pass that budget bill and kind of go away for a couple months. Everybody enjoy the summer, go on vacation, whatever. So that usually is a time where people clear up things like that. They want to, I think, try to be in a position where at least they capture common ground.
All right, thank you.
Thank you.
now, the late fee beginning on 9/16, is that after midnight on the 15th up until midnight on the 16th, or is it?
As of midnight, 2000, September 15th,
Got it, okay.
and when that day ends, if it's not a completed renewal application as of switching over to 2016, you could late fee.
That's the fee, okay,
Yes.
got it.
September 16th, I meant, sorry. Yes,
At
12.
12:01, yes, got it.
Oh,
Because you
And
know,
then
that spike,
yeah, 1 second, yeah.
that spike is probably gonna be around
Yeah.
11 p.m.
So, and what's key is, and we're working with the system administrators on this, is that it has to be, your renewal application cannot just be started on September, it has to be completed.
Just do
You'd be
it before
surprised.
September 15th.
You'd be surprised. So we are recommending, that you renew, early. We're sending out reminder emails already from the board. You should have all gotten, a reminder email about that. 3 that it should have at this point. The other thing we're doing is through the system, we're able to generate a series of emails. So let's say, renewal begins on July 1st. Well, then later in the summer, all those who have not yet renewed will get an email saying, reminder, you need to renew. And then as time goes on, hopefully those emails will be sent out to fewer people. Now, as an aside, because we are expecting 220,000 nurses to renew over the course of those few months, those, in the volume of emails, it's conceivable that you might renew on one day and be perfectly fine, you're renewed, but the next day you'll get an email that says, reminder, you need to renew. And the reason for that is because because of the volume, the system has to generate those over a series of days. So if that happens, just please look back at the public verification website, look back into your portal. You will see that your license has been renewed and that it expires in, 2021. So that's what you should see. So please just be aware of that. We're trying to be very proactive and get the information out there. I also ask that you help us to refer persons to the continuing education FAQs that are published on the board's website. They are updated to include dates for this current renewal period for both the separate RNPN and then the APRN FAQs.
Any other questions about relicensure? This wonderful time to be here.
Great. So then next up is a sample or summary of APRN practice questions. These are in your packet for your review.
And these are ones that came in since your last meeting, so this is a sample of those. So we always go by between meetings what's happening. So very recent.
Some of them are, like where do I find something, but some of them are also around scope of practice. Can I do this? Is this within my scope? So sort of underscores the need for something to help people answer these questions in the least restrictive way possible, but still consistent with current law. Comments or questions about that?
It just validates why we're doing what we're doing. I mean, some of these questions about, some are where do you find things and, what about, collaborating with physicians? I mean, I think those are all really big questions, but many of these questions are about scope of practice.
Michelle? I thought that interesting one, on number 3, when I was reading through these, it said, does the collaborating physician need to co-sign each chart that's reviewed per the nursing board requirements?